Welcome to this episode of the One Pathogen, One Review series. Today we are breaking down a quiet gut resident that has transformed into a major clinical threat, Enterococcus species. In this comprehensive, high-yield presentation, we will dissect everything you need to know for your boards and clinical practice, covering its morphology, unique cultural characteristics, biochemical identification, key virulence factors, disease spectrum, quantitative diagnostics, synergistic treatment protocols, and the critical molecular mechanisms of acquired vancomycin resistance. Clinical scenario and the opportunistic threat. Let's look at the clinical scenario. A 68-year-old patient admitted to the ICU is clinically stable until day 5, when they suddenly develop a spiking fever of 39.1 degrees Celsius, flank pain, and highly cloudy, turbid urine. An indwelling urinary catheter has been in place since admission. Urinalysis reveals heavy pyuria, and a urine culture is ordered, which grows a gram-positive, catalase-negative coccus that is resistant to multiple first-line antibiotics. This is a classic presentation of a catheter-associated urinary tract infection, or CAUTI, which represents the most common healthcare-associated infection globally, and serves as a frequent portal of entry for Enterococci into the bloodstream. Indwelling devices act as physical anchors, where catheter balloons serve as a physical nidus for Enterococci to adhere, form dense biofilms, and resist mechanical flushing. Critically ill patients in the ICU, experiencing impaired immunity and broad-spectrum antibiotic exposure, are highly susceptible to this endogenous commensal translocation. Morphology. Under microscopic examination, Enterococci are classified as gram-positive, oval-shaped cocci. When stained, they appear deeply purple under gram microscopy, reflecting a thick, rigid peptidoglycan layer within their cell wall. They feature a highly unique spectacle arrangement. Under oil immersion, they are arranged in pairs and short chains, with the pairs sitting at an angle to each other to give a distinct spectacle-shaped appearance. They are completely non-motile, lacking flagella, and they are non-sporing, which easily distinguishes them from other environmental bacilli. Additionally, analysis of their cell envelope reveals the presence of the group-specific D-lipoteichoic acid antigen in the cell wall, which is highly immunogenic in host tissues. When cultivating this pathogen, its colony morphology is key. On blood agar, Enterococci produce gamma hemolytic, translucent, gray, pinpoint colonies with no hemolysis surrounding the growth. On McConkey agar, they are highly unique among gram-positives because they grow readily, producing minute, distinct magenta-pink colonies due to active lactose fermentation. On CLED agar, they grow as yellow colonies, which makes this medium highly useful as an alternative for processing urine specimens. What makes Enterococcus an exceptional hospital survivor is its extreme resilience. Unlike other streptococci, Enterococci survive and proliferate under extremely harsh physical and chemical conditions, aiding their transmission in hospital wards. They easily pass the resilience test, demonstrating active growth in high salinity 6.5% NaCl broth, growth in the presence of 40% bile, and growth in highly alkaline media at a pH of 9.6. Furthermore, they exhibit a profound growth temperature range from 10 degrees Celsius to 45 degrees Celsius, and they can even survive exposure to 60 degrees Celsius heat for 30 minutes. To identify our isolate in the laboratory, we follow a systematic pathway. First, we must exclude staphylococci. Enterococci are catalase negative, producing absolutely no bubbling when exposed to hydrogen peroxide. This essential first step immediately differentiates gram-positive cocci, excluding catalase-positive staphylococci. Second, we utilize the bile esculin hydrolysis test. Enterococci readily hydrolyze esculin in the presence of 40% bile. This chemical breakdown reacts with iron indicators in the medium to turn the entire agar slant a highly distinct, deep black color. Third, modern clinical laboratories confirm species identification within minutes, using automated typing platforms such as mass spectrometry via MALDI-TOF or colorimetric reagent cards via Vitek 2. allowing us to rapidly distinguish between Enterococcus species, faecalis and E. faecium. How does this opportunist cause disease? It relies on a specific set of specialized surface-level virulence factors. The first is aggregation substance, which mediates pheromone-induced clumping. It promotes the aggregation and physical clumping of adjacent enterococcal cells, which is highly critical because it facilitates plasmid exchange, driving the rapid lateral transfer of drug resistance genes in the host. The second factor is the surface protein ESP, or extracellular surface protein. This specialized surface adhesion binds tightly to the host's bladder mucosa and the surfaces of indwelling devices. ESP expression is strongly associated with successful colonization, biofilm maturation, and persistent UTIs. Third, the cell wall antigen, group D lipoteichoic acid, stimulates host macrophages to release high levels of pro-inflammatory cytokines, such as TNF-alpha, inducing localized tissue damage and clinical inflammation. Enterococcus strikes several key clinical sites. First are catheter-associated urinary tract infections, or CAUTIs. Enterococci colonize the catheter surface and ascend into the bladder to cause cystitis, which can occasionally progress to pyelonephritis. Second is infective endocarditis, a highly devastating and destructive infection of the mitral and aortic valves, frequently observed in intravenous drug users or in patients following invasive urinary tract surgical manipulations. Third is chronic prostatitis, where the prostate acts as a resilient reservoir of infection. Enterococci sequester deep within prostatic tissues, where antibiotics struggle to penetrate, leading to recurrent bacteremia. Lastly, they cause neonatal sepsis and meningitis, which is a serious late-onset infection in newborns, acquired via vertical transmission from a colonized maternal genital tract during delivery, or through horizontal contact in neonatal wards. When establishing a laboratory diagnosis, we must utilize the CAS concept of quantitative urine culture. Normal voided urine is sterile, but frequently becomes contaminated with urethral commensal flora during voiding. Dr. Edward Cass introduced quantitative thresholds to differentiate true infection from contamination. In clean catch voided urine, a count of greater than or equal to 10 to the 5th CFU milliliter is considered significant bacteriuria, indicating an active UTI. However, in symptomatic catheterized patients, a count of greater than or equal to 10 to the 3rd CFU milliliter is considered highly significant, reflecting the rapid pooling of urine around the catheter balloon. Counts between 10 to the 4th and 10 to the 5th CFU milliliter fall into the doubtful range and must be correlated with patient symptoms. For specimen collection protocols, midstream urine is the gold standard for uncomplicated UTIs, collected after discarding the initial voided stream to wash away urethral contaminants. For catheterized patients, urine must be drawn directly from the catheter port using aseptic technique. Collecting urine from the drainage bag or urobag is strictly contraindicated due to massive, rapid bacterial multiplication in stagnant urine. For suspected endocarditis, always collect 2 to 3 sets of blood culture bottles from different venipuncture sites to document persistent bacteremia. When planning clinical therapy, our approach is highly stratified. Uncomplicated UTIs are highly responsive to oral monotherapy, including ampicillin, nitrofurantoin, or fosfomycin, all of which achieve excellent therapeutic concentrations in urine. However, for serious invasive infections like endocarditis or meningitis, monotherapy is completely insufficient. The treatment of choice requires mandatory combination therapy with penicillin or ampicillin plus an aminoglycoside, typically gentamicin. If the strain is ampicillin resistant, vancomycin is utilized as a first-line alternative. If vancomycin-resistant VRE is present, daptomycin or linezolid must be initiated. The molecular mechanism of synergy is beautiful. Aminoglycosides are intrinsically unable to cross the highly impermeable cell wall of Enterococcus. Synergy is achieved through a coordinated biochemical attack. In Step 1, ampicillin or penicillin inhibits peptidoglycan cross-linking, causing physical cell wall damage. In step 2, this damaged cell wall permits gentamicin to easily enter the cell and bind to the 30S ribosomal subunit. In step 3, this combined dual-target action achieves highly potent bactericidal killing that neither drug could ever produce alone. Resistance and VRE. Let's look at the intrinsic and acquired resistance profiles of Enterococcus. Enterococci are naturally intrinsically bulletproof against a vast array of antimicrobials, which severely limits clinical options from the outset. They are intrinsically resistant to cephalosporins, meaning broad-spectrum drugs like ceftriaxone should never be used as monotherapy. They are intrinsically resistant to aminoglycosides as monotherapy due to low cellular uptake. And they are intrinsically resistant to clindamycin and cotrimoxazole. Additionally, E. gallinarum and E. cassiflavus show species-specific intrinsic resistance to vancomycin. Acquired resistance, specifically Vancomycin-Resistant Enterococci, or VRE, represents a major clinical and infection control emergency in hospitals. VRE is primarily seen in E. faecium and is driven by the acquired plasmid-mediated VAN gene family, specifically the VAN A and VAN B genes, which can be horizontally transferred to other gram-positive organisms. The molecular target site alteration is highly elegant. Normally, vancomycin binds tightly to the D-alanine terminus of the peptidoglycan cell wall precursor, blocking cross-linking. The VAN genes synthesize an altered target, D-alanyl D-lactate or D-alanyl D-serine. As a result, vancomycin exhibits close to zero binding affinity for this altered target, leaving the cell wall free to cross-link and remain fully functional. Severe VRE infections are managed with newer agents, including linezolid, daptomycin, or streptogramins. Though note that streptogramins are active only against E. faecium, not E. faecalis. To conclude our review, let's test your knowledge with 3 high-yield clinical board questions. Question 1 asks, which set of growth conditions is highly characteristic of Enterococcus species and differentiates them from other gram-positive cocci? The correct answer is B. Growth in 6.5% NaCl, 40% bile, pH 9.6, and at 45 degrees Celsius. Enterococci are exceptionally resilient and uniquely grow in extreme salinity, high bile concentrations, and wide pH and temperature ranges. Question 2 asks, what is the molecular mechanism of resistance in Vancomycin-resistant Enterococci carrying the VAN A or VAN B gene? The correct answer is C. Alteration of the cell wall target from D-ala-D-ala to D-ala-D-lac or D-ala-D-sur. This structural alteration dramatically decreases vancomycin's binding affinity, rendering the antibiotic completely ineffective. Question 3 asks, which antimicrobial agent is Enterococcus species intrinsically resistant to? The correct answer is B. Ceftriaxone. Enterococci are intrinsically resistant to all cephalosporins, cotrimoxazole, clindamycin, and aminoglycoside monotherapy. This wraps up our slide-by-slide guide. Thank you for listening, and good luck with your clinical boards.